Hi, my name's Lynn Shields from NHS Grampian, and I'm going to present my Masterclass project, which is looking at our care home population and how we can best meet their needs. And I'll also explain why I am a disembodied voice as we go along. I thought I'd just start by explaining a bit about our service. So for those of you whose Scottish geography is as rubbish as my English, this is a map of Grampian. It's a large geographical area with our main population based in the city of Aberdeen. There's also a big population in the city of Elgin, but this is looked after by Vic Henderson, who's at the course today, so I'm not going to talk about this. And Grampian also looks after the islands of Orkney and Shetland, which you may have spotted or not on this map. We've got a number of peripheral clinics, and increasingly our clinics are moving more to integrated multidisciplinary clinics. Our main setting in Aberdeen is already there, and the two clinics I've taken on as a consultant in Stonehaven and Banchory are some way to being multidisciplinary clinics, with one having an occupational therapist and one having a physiotherapist on top of the standard model of geriatrician and Parkinson's disease nurse specialist. So increasingly, if you live in your own home, you're being seen in a clinic with access to a number of the multi-professional team. If, however, you live in a care home, our model hasn't changed and you tend to be seen about annually by one of our Parkinson's disease nurse specialists. There are some care home residents who do still come to clinic, and equally there's some people in their own homes who decide coming to clinics is too much and again get seen at home by the Parkinson's disease nurse specialists. You could argue that we should keep bringing people including those in care homes, to clinics to get this MDT input, but we find that most of them don't want to due to either mobility or neuropsychiatric problems, or the logistics of getting them from care home to clinic makes that unmanageable. So this has left me a bit worried that potentially we're disadvantaging the group of people who are resident in a care home. In an ideal world, we would take our multi-professional team to them and provide clinic level input in the care home, but this is unlikely to be viable without a significant investment of time and money, which isn't going to happen, as it would be much less time efficient than running a clinic, and probably these are the group of people I thought that would have the most complex disease, and we'll go on to see if that's true later. So some of my thoughts for how I wanted to address this when I take on the service are: I wonder about regular tabletop discussions of all care home residents with Parkinsonism following the Parkinson's disease nurse specialist review, and we could do this at the end of a clinic just by adding an extra few slots on, and we could do a care home or two at a time. The benefit of this is that we've got a similar model with a lot of our GP practices, where we meet with the primary care team and discuss all care home residents and do polypharmacy anticipatory care planning reviews, and also do this for older adults with frailty living in their own homes with many GP practices. So it's a system that we're used to, and it would also hopefully help us identify those people in care homes that would benefit from other members of the multi-professional team seeing them. It would also allow us, I think, to have a more systematic approach to reviewing them, making sure that we're encompassing motor symptoms, non-motor symptoms, and anticipatory care planning. Some of the pros and cons I thought for my proposed model: I think the pros are improved access to the MDT, a relatively time efficient way of reviewing them. It allows better documentation, and I think this may well impact on our PD audit results, because I think some of the areas we did poorly in were more to do with documentation rather than our comprehensiveness of our review. And it could help to engage care home staff, which would hopefully help with education around Parkinson's. Some of the cons are it's definitely still not equal to the service we're offering at the MDT clinic because the person isn't present. It may well increase workload, although anecdotally I feel like I do get these people discussed with me by the Parkinson's disease nurse specialist. So I think it's probably just restructuring the work and putting it in at the end of the clinic rather than in an ad hoc fashion, but I wouldn't know that for sure until we did it, and it may well be difficult to get care home staff engaged in this. But probably the biggest potential con is I've got absolutely no idea if it would work. So I think that I need to know as much about the care home population as possible to design a system that best suits them prior to implementing it. So before I go on and talk about my project, I need to get my excuses in. Since I saw you last, I've had a baby who spent most of his first few months crying. This is him at baby massage, which as you can see he totally loved. And this has rather limited my ability to do much of a project. I'm a bit of a quality improvement enthusiast, but recognised that there was no way I was going to be able to have the time or clinical contact to do a service improvement project. So I've instead focused on our care home population's demographics and current level of input, with the aim to implement a new model once I'm back at work. Here's a slightly nicer picture of him so that you don't go away with the view that he always cries, he just mainly cries. So my project is to understand our care home population better in order to improve the service we deliver. And the way I went about doing this was accessing the database that's used by the Parkinson's disease nurses to identify people who live in care homes. I then looked at their electronic records to collect data from clinic letters and from appointments, and compared some of this data with our local PD audit results from 2015. There are some limitations to this project. The database is updated manually, so it may well not be up to date, and certainly there were a few people who were still in the database who had actually died since then, and I'm sure there's people who have moved into care homes that I don't know about. I didn't look at paper records, but I don't think this is much of a limitation because our electronic records go back a number of years now. And what I've documented in the results is based on what's documented in letters, so it may well be there have been more discussions about things like non-motor symptoms, it's just not documented in the letter, but if it's not documented, I've said it's not happened. So looking at the whole Grampian PD population, there's about 1,128 patients and about 90 of them live in a care home, which is about 8% of the population, which is roughly equivalent to the national data from 2015. Now, because of the previously mentioned high maintenance baby, I didn't have time to look at all 90 of Grampian's care home residents, so instead I focus on those just in my patch, which is South Aberdeenshire and Royal Deeside. I've included some pictures to show you how horrible these areas are. The one on the left is Dunnottar Castle in Stonehaven, and the one on the right is Cathas Castle in Banchory, where my two clinics are held. So, looking a bit about the demographics of my population, there are about 124 people and 23% of them are under neurology, so I look after 77%. I was a bit surprised by this. I thought that geriatrics looked after the majority of people or looked after almost all people in care homes. Now we've got a big epidemiological study into PD in the north of Scotland, the PINE study, which is run by one of our neurologists. So he keeps anybody that's been enrolled in the PINE study so that he can follow them up. So I suspect this is why such a big proportion seem to still be under the care of neurology. There was 13 people in my catchment who lived in care homes, which is about 10% of the population, and I'm not really sure why this was higher than the rest of Grampian or the national data. The numbers are so low it may just be random. The average age was 81, which isn't much of a surprise, and roughly 2/3 were in a nursing home and roughly 1/3 in a residential home, which again isn't much of a surprise. And neither's duration of disease, although there were a few people with relatively new diagnoses, but the majority of them had had it for a number of years. Again, not much of a surprise, the majority of people had a diagnosis of idiopathic PD, but there was one person with PSP and one with dementia with Lewy bodies. What I did find surprising was the rates of dementia, which were lower than I suspected. Although looking through the clinic letters, I suspect that quite a few of the people without a diagnosis actually did have. So it might be a problem with our rates of diagnosis rather than it being that rates of dementia are lower in the care home population than I expected. And again, not unexpectedly, everybody in a care home with Parkinsonism was either in the complex or palliative stages of the disease. I also looked at the Hone and Yar staging, but everyone automatically was stage 4 because they were unable to live on their own, so I didn't find that useful to include. Then went on to look to see how often we're seeing our care home population and also what member of the team is seeing them. And almost everybody was last seen by the nursing staff. One was last seen by a consultant. And we're doing not bad in the majority of them were seen within the last year, although one was over a year. What we're doing less well at is time since consultant review, and as you can see, there's a significant group of people who haven't seen a consultant for over 2 years, although I should add that one consultant review was delayed due to repeated hospital admissions rather than a problem with our system. Then looking at whether they'd been seen by an AHP, only 4 of the 13 had been reviewed in the last year, which surprised me, 2 by OT and 2 by SALT, which means that 9 people had no allied healthcare professional review, which given their levels of complex and palliative disease, I'm surprised about. We also don't have any access to AHP reviews and recommendations, unfortunately, on our electronic systems, which again is something we need to look at. Then went on to look at anticipatory care planning, where we did awfully. There was only one mention of ACP in clinic letters, and this was in the patient with PSP, probably unsurprisingly, and it looks like it was actually raised by the daughter rather than being instigated by us. Then went on to look at whether people had any discussions about things that make up anticipated care planning, like DNA CPR discussions, place of care, wishes, and also something called the key information summary, which is something done by GPs where it records people's medical problems and their healthcare wishes, including things like DNA CPR and place of care. And we did probably better than I thought we would, but still room for improvement, especially around place of care. Then looked at non-motor symptoms. I need to bear in mind that these may well have been asked about and just not documented in a letter. I've chosen to focus on neuropsychiatric symptoms and bowel and bladder symptoms, as I think these are probably the most common reasons for admission to a care home in people with Parkinsonism, and they're often associated with a significant reduction in quality of life. Continuing the theme of boring you with pictures of my baby, here he is clarted in poo. And as you can see, we did pretty awfully. We only discussed bowels and bladder in 15% of the people we saw. Neuropsychiatric symptoms we did better, but there's still 38% of people that we didn't ask any questions about neuropsychiatric problems, which again isn't good enough. So what I've learned by doing this, that there are a significant number of people in care homes, and as expected, they are the people with the most complex disease. They have very low levels of consultant and AHP input and very little discussion about anticipated care planning or non-motor symptoms. So what I think my next steps are is I'd quite like to look at the care home population in Grampian as a whole to make sure that I've got a representative sample. I then think that we need to discuss these results with other stakeholders, so the Parkinson's disease nurses, GPs, neurology, and also the care home residents and carers, so that we can introduce a system to improve MDT discussion and access and improve the comprehensiveness of our review for this group of people. And once I've done that, I'd like to pilot this in Stonehaven when I return from mat leave. And my guess is that this is likely to take a tabletop style format following Parkinson disease nurse review with a set pro forma. Any questions or comments, please give me an email. And I just want to say thanks to Dr. Conor Maguire for mentoring me with this. Thank you.